anxiety disorders in older adults. And the first few slides I'll run through quite quickly. They're just disclosure slides. So as David mentioned, there are a number of affiliates and sponsors for this ECHO session. My own disclosures are a number of grants from peer-reviewed funding agencies, and as well as medications donated by two pharmaceutical companies for NIH studies, but those companies had no other involvement in terms of the research. And I don't have any other affiliations with industry. And just as David mentioned, the program has support from the RBC Foundation, but no other support and no other conflicts of interest. And the information presented today is as much as possible evidence-based information, and I will be highlighting drugs that where we may have off-label use of those drugs when we discuss them. So let's begin. So in terms of the key messages or learning points, these are the points I'd like to convey during the presentation. First of all, anxiety disorders, it's a plural. So it's not, anxiety is not one thing. It's a heterogeneous group of disorders when it comes to classifications like DSM-5. But as I'll be noting also, anxiety in both older and younger people often presents as a subsyndromal condition, which doesn't actually clearly meet criteria for a DSM type disorder. The second point is that late life anxiety is often symptomatic of another condition. So unlike anxiety in younger people, where it often does tend to be more discrete and more clearly meeting criteria for DSM type disorder, in late life, this becomes a bit murkier, and often we'll see anxiety in association with other conditions. And the condition to think about in particular is depression. Even when you're talking about people who are medically unwell or people with cognitive impairment, the thing to dig for is whether there's an underlying depressive disorder where the anxiety is associated with it. The third point is to make a diagnosis. So the temptation, I think, is simply to see people who are anxious and distressed and leave it at that. And so you need to, in order to come to clarity about how you're going to manage the person optimally, you really need to dig down and try and come to a diagnosis, as opposed to simply saying the person's anxious. And in the past, and to a lesser extent now, but still to some degree, the reflex for that has been to prescribe a benzodiazepine and or a sleeping medication as a symptomatic treatment when one has been confronted with an anxious person. And as we'll discuss, there's way more to treating anxiety than simply prescribing an anxiolytic like a benzodiazepine. So the issue about heterogeneity. Anxiety is heterogeneous from the point of view of a spectrum of severity of anxiety, as well as in terms of meeting disorder criteria. So as everybody knows from their own experience, and anxiety is a normal mood, it's a normal experience, and it can be adaptive in certain situations. And it then runs through the gamut of clinically significant subsyndromal anxiety symptoms to what we would call syndromal anxiety, which are the discrete anxiety disorders, which are described in classificatory systems. So in terms of subsyndromal anxiety, what do we mean by this? So subsyndromal anxiety are anxiety symptoms that don't clearly and neatly meet criteria for a specific disorder. And as I mentioned before, much of the anxiety that we deal with is in fact subsyndromal anxiety, and it's not neatly classified. And it's subsyndromal for a couple of reasons. One of them is that just basically there are insufficient number of symptoms or insufficient intensity of symptoms to meet criteria for disorder. And in older people, mixed anxiety and depression, especially in clinical practice in primary care is a very common manifestation of anxiety. So a person may not clearly meet criteria for a depressive disorder like major depression, and they may not meet criteria for an anxiety disorder like generalized anxiety disorder, but they have clinically significant and distressing symptoms of both anxiety and depression that still requires some degree of management. And the other reason it's subsyndromal is that there may be qualitative differences. So what we often will see are people who have symptoms of generalized anxiety that don't meet criteria for the disorder. So they don't have excessive uncontrollable worry with a number of other physical symptoms, but they just have this pervasive sense of feeling on edge and uptight and maybe apprehensive, which lasts through the day, but it doesn't clearly meet criteria for a disorder. It's also very common for people, older people, if they're anxious, to describe feeling panicky, but they don't have specific panic attacks. So a panic attack is when there's a sudden onset and then a sudden offset of symptoms dominated by a sense of fear, and often with associated physical symptoms like autonomic symptoms like a racing heart and difficulty breathing or a feeling of fullness in the throat. And generally those panic attacks last in the order of 10 to 30 minutes. But it's not uncommon to have older people talk about feeling panicky without having panic attacks. And the thing about feeling panicky is that often this description can last an entire day, which would not be the case for a panic attack. And finally, a lot of people with anxiety may feel fearful without actually having criteria for phobia. And the reason they don't have the phobia is that they don't have the avoidance. So for a phobic condition, you need both the fear and the avoidant behavior that goes along with the fear. And we'll talk about this in more detail later. But it's not at all uncommon for older people to be fearful, but without the phobic avoidance. And I'll talk about why some older people don't have the avoidance behavior. Understanding the epidemiology of anxiety disorders is helpful because it gives us a perspective on the most frequent conditions in life in anxiety disorders in older life, as well as those which are chronic and those which are newer or onset or later onset. So anxiety disorders are common in older people. They have a prevalence of 5 to 10%. So arguably they're the most common in condition, more so than strictly defined depressive disorders or dementia. But they are less common than younger adults, and multiple epidemiologic surveys from many countries across now the last 30 or 40 years have consistently shown that anxiety disorders are less common in older people than younger people. And we can talk about this in discussion about why this may be the case. There may be a number of contributory factors which doesn't diminish the importance of anxiety in later life. And as I say, a lot of these people may in fact not meet criteria in epidemiologic surveys because they have subsyndromal symptoms. But if we do take the disorders, the most common disorders in later life are generalized anxiety disorder and phobic disorders. And the two phobic disorders are specific phobias and agoraphobia, which is a fear of open spaces. The least common anxiety disorders in late life are panic disorder and obsessive compulsive disorder. So when we talk, when we just by probabilities, when we see older people, if they're anxious, the more likely thing is that they either have a phobic disorder or generalized anxiety. So these are three key questions when you see an older person with anxiety in terms of helping your evaluation and start thinking about, in fact, what type of anxiety they may have. So what stage of life did the anxiety start? So in your history taking, this is a very important question. You really need to take a longitudinal approach and find out when in life did their anxiety start. Because as I've just mentioned, there are some disorders which rarely start in late life. And if a person has them, they started when they were younger, either in childhood or their adolescence or in their early adulthood. Whereas there are other disorders which can start for the first time in later life and are newer onset disorders. And then the next question is, does the person have a primary anxiety disorder or is the anxiety secondary or symptomatic of another condition? And as I had said earlier, it's very important to make this distinction, because if it's symptomatic of another condition, you really need to treat the primary condition rather than simply symptomatically treating the anxiety. And the other conditions you need to think about are either a depressive disorder, dementia, physical illness that could be either directly contributing in a physiologic way, or else it's anxiety in the context of the disability and distress of the physical illness. And finally, drugs. And when I'm talking about drugs, I'm not just talking about prescribed medications. There are other drugs. There are alcohol and over-the-counter drugs, as well as other recreational drugs. So to come to the question, when did the anxiety begin? As I mentioned, obsessive compulsive disorder and panic disorder rarely start for the first time in later life. And so if you see someone with these disorders, usually, especially with obsessive compulsive disorder, it probably would have started in their teenage years or early 20s. And panic disorder rarely starts as a de novo condition, and in other words, a primary disorder. It rarely starts after the 30s. Specific phobias, phobias where people may have fear of animals, fear of blood, for example, fear of other specific situations. These tend to be childhood disorders. They, again, rarely start for the first time in later life, with one exception, which is fear of falling, which I'll come to, which is difficult to categorize in terms of phobic disorders, but in some cases may be categorized as a specific phobia. But fear of falling is a common condition in later life. But more traditional phobias, as they things like fear of heights, fear of animals, fear of blood, and so on, these are things that start when a person is a child or an adolescent. Generalized anxiety disorder is equally split between generalized anxiety that starts in early adulthood or the teenage years, and then generalized anxiety that starts late in life. And of the cases that start late in life, of the 50% that starts late in life, that can again be split into GAD that basically is symptomatic of depression. So the anxiety starts when a person becomes depressed, and it goes away when the depression improves. And then the other group in late life are the people who develop GAD for the first time in late life, and they're not significantly depressed. And in those people, the GAD is usually in the context of physical illness. Usually, sometimes other issues can contribute, like financial instability, but it's usually in the context of physical illness. And the other conditions that start in later life are agoraphobia and post-traumatic stress disorder. And post-traumatic stress disorder is an interesting one, because that can start at any stage of life in relation to a trauma, whether it be an individual trauma, like an assault, for example, or a mass trauma, such as an environmental trauma, like an earthquake or hurricanes or whatever, or some other type of disaster. And obviously that can affect people at any stage of life, and older people are not immune to developing PTSD. But another interesting aspect of PTSD is people have had traumas earlier in their life, and they didn't develop PTSD symptoms at the time of the trauma, but the symptoms become apparent later in life in relation to some of the stress that a person's dealing with. And all of a sudden they start developing traumatic symptoms that may be related to a trauma that's happened to them several decades previously. And some of the classic descriptions around this have been with Holocaust survivors, people who were in concentration camps during the Second World War, who didn't have clear-cut symptoms of PTSD after that experience, but only developed them later in life, when other things started happening, other life changes started happening to them. Generalized anxiety then is an important thing to know about, because as I said, this is really one of the two most common manifestations of anxiety in later life, next to phobic disorders. And the core feature of GAD is excessive, multiple, uncontrollable worries. The primary complaint, though, is often not anxiety, and people come to primary care and they often don't complain of anxiety, but they can have a lot of unexplained physical symptoms, such as fatigue, aches and pains, GI symptoms, and insomnia. And these are the frequent flyers who constantly come back with different complaints. And it's only when you start digging down that you realize that they may in fact have an underlying generalized anxiety disorder. And as I mentioned before, this disorder in late life is frequently associated with depression. And if you treat the depression, then the anxiety symptoms will often improve or remit. Agoraphobia in late life. So agoraphobia is when someone develops a fear of going out, leaving the home, or being in open spaces. In younger people, agoraphobia often develops in relationship to panic attacks. Often people have panic attacks and then they become avoidant of the situation in which they had the panic attacks and eventually become homebound. Whereas there really is very little relationship between panic and agoraphobia in later life. And most agoraphobia in late life develops in the context of physical illness or traumatic events, such as having had a significant fall or having had, for example, a heart attack. Again, agoraphobia can develop in the context of someone being depressed, but depression can also be a consequence of someone who develops agoraphobia outside of a depressive illness, and they become depressed as a result of the activity and social restriction. And the other thing about agoraphobia is it really ever comes to psychiatric attention, and so it's often not treated. These people tend to suffer in silence. They're often homebound and not detected when it comes to medical services. Fear of falling is a common condition in later life that, again, we can discuss during the discussion period if this comes up. Is quite common amongst fallers, but it can also start in people who have not fallen. And again, you'll start to see the common theme here. In those people who have not had a fall, but develop fear of falling, it is usually starting in the context of a depressive illness. And again, you treat the depression and the fear of falling will often improve. In terms of dementia, anxiety disorders are not more common, not more prevalent in dementia versus people who don't have dementia, but anxiety symptoms, and these are very non-specific anxiety symptoms, are very common in people with dementia, especially as dementia starts to progress. And so estimates have been that 20 to 40% of people with dementia have symptoms of generalized anxiety at some point of their illness. Again, frequently in association with depression. And the other point is that anxiety is not the same as agitation. So people with dementia are frequently agitated, especially in more severe stages of the illness, where they'll be pacing, vocalizing constantly, and so on. The agitation is a motor behavior and is not necessarily implying the person is anxious. But at times it can often be difficult to disentangle the two in someone who has more limited ability to communicate their distress. But it doesn't necessarily imply the person is anxious. It may simply be a motor manifestation of the dementia. And finally, before we talk about treatment, because time is marching on, anxiety associated with physical conditions. So this may be a normal or pathological response to the physical illness. So it may be quite an appropriate response to being physically unwell, or it may be out of proportion as a response to the physical illness. Always remember that it can be a manifestation of the physical pathology. So if you have sudden onset anxiety in an older person, they should have a basic medical workup, looking for things like thyroid dysfunction, hypercalcemia, and other potential causes, again, guided by clinical history, as well as physical examination to point you, maybe if you're thinking about a particular physical cause. And also bear in mind that it's not at all uncommon for older people to develop anxiety in the context of either drug toxicity or withdrawal. And the withdrawal is often either alcohol or sleeping medications or anxiety medications. So they're already receiving medications for sleep or anxiety. And they then, these symptoms can then lead to rebound anxiety symptoms or worsening anxiety symptoms as the effects of the medication start to wear off. So let's turn to treatment and management. In terms of treatment for anxiety, essentially it's either psychological treatments, medications, or both. And in terms of mixed age populations, young and middle-aged adults, the treatments that have been found to be most useful are relaxation training for generalized anxiety disorder, exposure therapies for people with phobic disorders or the compulsions of OCD, and then more widely used cognitive behavior therapy, which has elements of relaxation training and exposure as well as other cognitive exercises. And this is effective in a broad range of anxiety conditions. When it comes to older people, the only controlled trials that have been conducted have been for generalized anxiety disorder. So there have not been any other randomized controlled trials of psychological treatments for other types of anxiety in older people. And what we know about the trials that have been done is that cognitive behavior therapy is less efficacious for generalized anxiety disorder in older than younger adults. And in fact, in some studies, there's been no more efficacious than a discussion group or supportive therapy. And a meta-analysis, which was conducted a while ago now, found, in fact, that medication therapy was actually more effective than CBT for late life anxiety. One of the reasons that CBT may be less efficacious is to do with some of the cognitive changes that older people experience and their ability to use cognitive strategies. They tend to not persevere with homework exercises as much, which are a central part of CBT. And also when you look at adherence with CBT in terms of attending sessions, older people have more difficulty actually adhering to the program in terms of attending the sessions that's required to gain mastery in CBT. So there are a number of practical limitations for CBT. It doesn't mean it's not effective, but I think one has to be a little more circumspect in terms of the efficacy in older individuals. In terms of medications, this is a busy slide, but the point I want to make here is that if you look at the first 5 rows, the top 5 rows of this slide, these are all antidepressant medications. So SSRI medications, serotonin and noradrenaline reuptake inhibitors such as venlafaxine or duloxetine, tricyclic antidepressants, monoamine oxidase inhibitors, and trazodone. These are all so-called antidepressants, and yet we know that a broad range of antidepressants also have a broad range of anxiolytic effects, both in treating anxiety in context of depression as well as discrete anxiety disorders. And benzodiazepines, which are often the first used by practitioners to treat anxiety, in fact have a more limited role in treating anxiety disorders. And are limited actually in terms of controlled trials to treatment of generalized anxiety, panic disorder, and social phobia. When it comes to older people, again, the only studies that have been done in terms of randomized controlled trials have been in generalized anxiety disorder. So all the treatment recommendations for other anxiety disorders have to be extrapolated from drugs that have been found to be effective in younger people. And when it comes to GAD in older people, essentially, we're talking about 2 SSRIs, citalopram and escitalopram, 2 SNRIs, duloxetine and venlafaxine, and then one very old study from the 1960s with oxazepam, a benzodiazepine, and then buspirone, which has rather circumscribed and limited use in treating generalized anxiety in older people. And it also has been work with Seroquel or quetiapine, although this is not FDA approved. This does not have approval in terms of an indication for anxiety disorder, but it's often used off-label in low doses to treat anxiety in older people. In terms of use of these drugs, the key message here is to start them at very low dosages because sometimes starting these drugs can, at the usual dosages to use to treat depression, can actually amplify the anxiety, even though they later lead to improvement in the anxiety. So you start with very low dosages, but then also bear in mind you want to reach a target dose And then if necessary, if the person's still not responding, but they're tolerating the drug, to then move up to a maximum dosage as tolerated. So the usual geriatric psychiatry or geriatric maxim, start low, go slow, but then push the dose as tolerated to a therapeutic dose. Before we finish, just a couple of words about benzodiazepines. So benzodiazepines, I think people are taking a much more judicious approach these days to using benzodiazepines than used to be in the old days. But to bear in mind that these drugs are associated with quite a number of adverse effects. So cognitive impairment, psychomotor impairment in terms of balance and gait, which can result in falls, excessive sedation during the day, especially if given in combination with other sedating drugs, the potential for depressed respiration in people with things like chronic airways disease, and potentiation of other CNS depressant drugs, not only antidepressants, but drugs like gabapentin, for example, which are used for chronic pain conditions. And of course, people are very aware of the fact they can lead to dependence and withdrawal syndromes. So the risks are numerous. The risks can happen at low dosages, at the same dosages that lead to efficacy. So the risks aren't just simply associated with very high dosages. So even a drug like lorazepam, which is preferred in older people, if you're using lorazepam at a dosage of, say, 1 milligram or 2 milligrams a day in an older person, the risks can outweigh the benefits in terms of risk of falls and cognitive impairment and so on. So there's no doubt, though, that benzodiazepines are tremendously efficacious for symptomatic anxiety in older people because they act almost immediately within the first dose or two. People find that, especially if they're benzodiazepine naive, they've never had benzodiazepines, they're very effective within a short period of time in relieving the anxiety. And this is why people can become dependent on them and then not be able to get off them. Whereas the other drugs I was talking about can have a delayed effect. It can sometimes take a few weeks before they become efficacious. So drugs like lorazepam can have some role to play in the short-term management whilst one is treating the anxiety with other medications in terms of longer-term treatment. But you have to be very careful in terms of defining a duration of treatment, both in your own mind as well as with the patient, and then making sure you stick to that duration and then gradually discontinue the drug once the person has started to respond to other treatment modalities. So have a plan of action if you are going to use a benzodiazepine. And just one last mention of other things. So vortioxetine, which is a serotonin modulator, as well as SSRI. There've been mixed results in generalized anxiety disorder, and it's a very expensive drug, so it doesn't really lead to any additional benefit over SSRIs or SNRIs. Mirtazapine, anecdotally, is useful for treating anxiety in association with depression, but no randomized controlled trials. And people may ask about what about cannabinoids, and the evidence is insufficient to really recommend their use. The trials that have been done in anxiety and depression are very poor quality, based on very small numbers of people with poorly defined outcomes. And right now, there's not sufficient evidence to recommend the use of cannabinoids to treat anxiety in older people. So to conclude, coming back to the points I made before, keeping in mind that anxiety disorders are heterogeneous, there's not just one thing. It's often symptomatic, and again, just to underline the fact that if you see someone who's anxious, you should look for depression in all cases. And if they are depressed, treat the underlying depression. Make a diagnosis in terms of what type of disorder you're dealing with, and then treat the underlying conditions as well. So I'll finish there, and we'll open things up for discussion.